Good afternoon, ladies and gentlemen. My name is Mike Duffy. I need help. No, it's worse than that. It's Rex Murphy. It's very intimidating to be here, as some of you may know. As I was going to say, some of you may know I worked for a fairly long while with CBC Radio, so I'm not used to large audiences. No, I should explain why I'm here. We have, and I will be introducing them very, very shortly, three people of academic distinction, high intelligence, and real information, and then there's me. But I'm here for a couple of reasons. One is that about, 3 or 4 or 5 years ago, I should keep track, I had a heart attack, and these people here engineered my continuance on the planet, which doesn't speak well for the institute that I went to. But they did say if I didn't agree to these kind of things, they'd make sure the next time the results would be different. No, they're actually quite good, despite that. Secondly, just as a kind of, I'm not going to have an Oprah spasm or anything, but let me share a few things with you. One of the things that most impressed me when I basically paid the cost of my dissolute life was that the same thing occurred to my father about, 30, 35 years ago. Identical age, and more or less identical situation. And without being Dickensian or anything, for him it was fatal. It was just simply as simple as that. And 30 years on, plus the advances in technology and research and the skill of the people in hospitals who deal with these things, in my case, not to be flippant, it was almost casual. You go in and they perform things that were miracles in the eyes of our fathers or grandfathers or grandmothers or mothers. And we've come to take it so quickly for granted. And it never leaves me, and that's the only personal thing I will say, that my poor old father was in a different time and a different place. And after a life of real work, as opposed to journalism, he worked from the age of about 14 in Newfoundland in the 30s, right up till the very end. Truly grueling, real work. And just as an irony, he was approaching 65 and about, for the very first time, to get a pension from the American naval station where he had worked. And he was looking forward in a kind of a bemused way for the first, as he called it, first free dollar that he ever got. And of course, the fates are always ironic, and it was cheated out of him. So just again, to round it up, it's impressed itself individually on my mind that the science, the research, the technical abilities, the skills, and the background really have elevated not only quality of life, but they have changed the whole pattern of what's normal and what's not normal. And looking back now, I have great melancholy that he had to go through so damn much and never really had the ability to relax. And I basically run a bluff for the last 50 years, and I'm still walking around. Life is not fair. Anyway, I should say a few words about the Krembil Research Institute itself. I expect that most of the audience are already aware of it. It was only a recent name change from Toronto Western Research. And the main areas of concern, as I've gotten them here, are brain and spine, bone and joint, and various other, with reference to the eyes in particular, glaucoma, macular degeneration, and other considerate factors. But the overall gathering here today is going under the rubric of aging well, and we have a distinguished panel, and it truly is a distinguished panel to kind of unravel some of the either concerns, mysteries, or great themes that attach themselves to people as they age. Aging well is a really large topic, mainly because we hit the demographic points of view that we see here, and because people are experiencing, as say my father did not, genuine longevity. These concerns, which once were critical, are now something that continue on or are chronic for a long period of time. So I'll give a brief sketch, and it will be informal. I'm going to do damage to the resumes that I got, mainly out of embarrassment. It's really quite humiliating to read these things. Well, it is. You say to yourself, well, I have no life. These people are, you know, I think one of them invented the combustion engine. I'm not going to tell you which one. I'll start over at Dr. Mahomed. He's the head of Division of Orthopedic Surgery. He is the Nicky and Bryce Douglas Chair in Orthopedic Surgery. He is the Smith and Nephew. He knows a lot of people. He's the Smith and Nephew Chair in Orthopedic Surgery. He's the Managing Director of Altum Health, and he's one of the main areas of research, and I'll let him expand on it himself, is arthritis. I'm skipping a lot because the biographies are so full, as I said, they're almost embarrassing. Next we have Dr. Valerie Wallace. She is the senior scientist here, scientific division head, research, Krembil Research Institute. Her area of research in particular, and I'm sure again this is a topic for here, is vision. Molecular and development biologist by training. She joined the Institute in 2013. She holds all sorts of grants. She's got more degrees than most thermometers, so we'll have a chance to talk to her. And right next to me, he drew the short straw, is Dr. I'm having a bit of fun, why not? Dr. Donald Weaver, senior scientist, Krembil Research Institute, director, Research Institute, focused on computer-aided drug design, medicinal chemistry, with particular applications to chronic, I'm going to get in trouble, neurodegenerative disorders, including Alzheimer's. Another great catalog and list. He has a University of Toronto affiliation, professor at the Department of Medicine, professor, faculty of pharmacy, adjunct professor, Department of, we can just, fill up the hour here. As I say, it's embarrassing, but they will let it go. I think the nicest way to start, if it's okay, and you have no choice, if it's okay with the three panelists, is if we could start from the far end and let each of the distinguished panel just give us a general statement either of your principal interest or of some theme that you think would be welcome to this particular group.
Thanks, Rex. Good afternoon, everybody. So as Rex said, I'm Nizar Mahomed. I'm an orthopedic surgeon who clinically I do hip and knee replacement surgery, and I've been doing that for the last 18 years. I have the honor and privilege to head up the group that is the Arthritis Program here at UHN, which is the constellation of orthopedic surgery, rheumatology, hand surgery, and osteoporosis. And together we're Canada's largest interdisciplinary arthritis program. And over the last 5 to 10 years, we've really taken significant strides forward in the area of arthritis research. Our goal is really to put ourselves out of the business. The risk of arthritis and its related disabilities to the population is going to continue to increase as the population ages, and the disability associated with this is enormous. As an orthopedic surgeon, what I do, is replace joints when they're worn out. And although this is an excellent operation, it's been around for a long, long time. Some of you in the audience who I can see have been recipients of this. But as good as this operation is, it's not the same as actually restoring your own joint to its original function. And that really is one of the key goals and thrusts of what we're trying to do here at the Arthritis Program. And the focus around regenerative medicine, precision medicine is really opening up new frontiers, and it's an exciting time to be here in the area of orthopedics and musculoskeletal disease.
Thank you, sir. Dr. Wallace?
Good afternoon. Thanks for being here. I'm a PhD by training, taking a long route to finally end up with working in vision-related matters. So I'm head of the Vision Research Program at the Krembil, and the Vision Research and Science Program at the university and UHN wide, and where we train students. So 1 in 20 Canadians has either a visual impairment or is blind. And 1 in 4 people by the time they're 75 is going to have a serious vision-related issue. And a lot of this is because we are getting older. And so our work is really related on trying to find treatments and better things that we can do for patients with some of the leading causes of age-related vision loss, like AMD, glaucoma, and diabetic retinopathy. And the program that I lead encompasses people working on understanding eye movements, so how the brain talks to the eye, and helping people see better after they have vision loss, And we have people working on trying to figure out how to look inside your eye without hurting you, to figure out where you are in the state of your disease. And finally, we have people working in the trenches, in the labs, trying to understand disease mechanism, because that's a lot of the information we're missing. And so, for example, in my program, we're trying to restore vision by transplanting healthy new neurons to the back of the eye. But there's a number of approaches that are all in the research phase that are all aimed at how do you preserve the retina in age-related conditions.
Thank you very much. Dr. Weaver, can you?
Hi, I'm hope I look better than the picture that's up there. Of all the pictures. Anyway, I'm Don Weaver. I'm the director of the Krembil Research Institute. The Krembil Research Institute is the research institute associated with the Toronto Western Hospital. Within UHN, we have the mandate for neurologic disease, arthritis, and vision. So clearly, those are three sort of different areas, but if you look at what are the three major disorders of aging that results in individuals ending up in nursing homes or chronic care facilities, it is in those three areas. So we are perfectly situated for dealing with disorders that more commonly affect individuals who are somewhat more advanced in age. From my own point of view, I initially trained as a neurologist. Then I went back and did a PhD in medicinal chemistry, so I make drugs. And sorry, that sometimes that doesn't come across well. And in particular, what we are focused on is trying to design drugs that will work against Alzheimer's disease and various other types of dementia. And so that certainly is my particular research area. Clinically, I also see individuals with Alzheimer's disease and dementia. I also see individuals who have epilepsy from a clinical point of view. Today is actually my clinical day. I'm quite pleased to be here. About 1 hour ago, I was seeing a patient, and I was putting this patient on a drug called valproic acid. I said two of the leading side effects of valproic acid are weight gain and hair loss. And the patient got very serious, leaned forward and said, "And how long have you been on it?" And that's when I said, I have a meeting to go to. So I am very pleased to be here.
We'll meet outside after to negotiate the transaction. Let me reverse the flow of it. I came from obviously a non-professional background, and I do remember that, again, I'll go back a little bit, 30 or 40 years ago, back in Newfoundland at least, what is now Alzheimer's had a lot cruder terms attached to it. But if you go back even further than that, you go back about 60 years, there was a different ethos, at least back home, when people that now, again, we would say are fairly deep in Alzheimer's, when families were all in a unit, the very oldest person who was, by that time, quite afflicted, would somewhere or other be bonding with the grandchildren because everybody lived in the same house. There was some sort of a linkage between the two, and it looked almost symmetrical and useful to both, which is, as usual, my long-winded way of just getting around. How much has either the attitude to or the remedies for this particular, I presume it's a set of conditions, how much has that changed?
Okay, so first of all, certainly all Alzheimer's is dementia, but not all dementia is Alzheimer's. If you look, it's about 70 to 75% of individuals who have dementia have Alzheimer's, and then there's many other types of dementia as well. Being able to differentiate those particular subtypes of dementia, we're actually pretty good at now, which say 50 years ago we were not. 50 years ago it was dementia, or senile dementia, was a sort of grab bag. And so nowadays we actually do have various categories which we recognize. So we do that better. The advantage or disadvantage of this is that we have better abilities then to provide prognosis on how fast the dementia may or may not progress because we recognize the subtypes. When it comes to treatment, Although we have medications available, they are primarily symptomatic, meaning they temporarily help with the symptoms, that is the memory loss, but really they do not affect the natural history of the disorder. And so Alzheimer's remains a constantly progressive disorder, and currently we don't have any medications that change that. We're working on it, and we have lots of approaches to that, but still in the clinic, not much has changed from that point of view. Now, the other part of the question was attitude. I think attitude has changed a fair amount. There's an increasing recognition that you can get old and not have dementia. There's lots and lots of elderly individuals who are perfectly cognitively normal, and that dementia or Alzheimer's is not a normal part of aging. It is a disease, and it's a disease for which we are researching and trying to find cures, but it really is separate, and I think that is a societal difference and change which really is quite significant.
Just one quick follow-up question for you in particular. Is there a relationship, or what is the relationship, if it does exist, between the fancy phrase cognitive decline and vascular conditions?
So that's a complicated question. We only have, okay.
They're relaxing.
Okay. So there is a type of dementia called vascular dementia, which is a pure vascular sort of dementia that arises from multiple strokes and decreased blood supply to the brain. So that exists by itself. There is Alzheimer's disease that exists by itself as well, and then there is an overlap. And so there are individuals who have both Alzheimer's disease and a vascular component or a blood supply component. And in fact, decreased blood supply to the brain from vascular disease is a risk factor for Alzheimer's.
I'll go now to Dr. Wallace. I understand, because it's been written for me, the 4 leading eye diseases affecting older Canadians are all age-related. Why don't you give the summary of what they may be? And in that particular case, is there any area that has changed radically in the field of vision in the older people?
Okay, so I guess the 4 you're thinking about are cataracts, glaucoma, age-related macular degeneration, and diabetic retinopathy.
You got them all 4.
Okay, I pass. So cataracts we can do something about, and the evolution of cataract surgery has been remarkable. So this is not a problem anymore. And we can even do better for people's vision with the type of cataract lens replacement we do. I don't do this. So the other diseases are, there's a tremendous overlap in terms of they're all neurodegenerative. They all eventually cause degeneration or loss of neurons in the eye. And you need these neurons to see. And it's very similar to what Don was talking about. These are diseases of aging. Not everyone will get them, but they're more and more prevalent. Why is the brain so sensitive? Because I don't think we were designed to keep going this long. And so there's that, and then there's also the interplay between who you are, what your family history is, and your environment. And there are modifiable risk factors as well. So, for example, smoking and AMD and diet and maintaining a healthy weight in relation to diabetic retinopathy. So I think these are just, some of them are unavoidable parts of aging, and but we don't completely understand the mechanism of those diseases, and we, for the most part, only have treatments that get at the symptoms, but once vision loss has happened, we can't fix that yet.
Is genetic disposition a greater contributor than any other factor, or is that a map that you can rely on in any way?
No, not really. So there are risk factors genetically, but they're not perfect, and we don't understand them. And again, those diseases are very complicated. They're going to be partly genetic, partly lifestyle, and mostly aging. Now, in terms of what's been one of the bigger advances, I guess that would be how we treat progressive age-related macular degeneration. So the majority of people have the dry form and maybe not too much vision loss, and then somehow that gets triggered into this wet form where blood vessels misbehave. And here's another link with the vasculature. And so over the last decades or so, the field has moved forward to using inhibitors that block immature blood vessels, basically. And that has been sight-saving for patients with AMD.
Just a personal one, because I did have some experience with it. What is the time or the operation for cataracts today? You say that's a much simpler procedure these days.
10 minutes?
Dear Lord. Now, the reason I asked the question, I had a fairly close family member. It wasn't 10 minutes. Mm-hmm. And it turned out not to be too successful either, but she got scared afterwards and wouldn't go back to get fixed. But that was then, as I said, a long while ago. Thank you very much. I'll go to Dr. Mahomed. I understand arthritis is one of the key areas in which you specialize. Am I right?
That's correct.
Why don't you give us a little riff on that, which is, again, a most common ailment? Yeah, he's laughing already. I'm going to meet him.
I'm going to take up the rest of the time now, Jim.
Go ahead.
No, so arthritis, as you've said, is very common. So one out of 3 people over the age of 65 is going to have arthritis. But arthritis just doesn't affect the elderly patient population. Arthritis is actually approximately 100 different diseases, of which what we commonly talk about arthritis is osteoarthritis, which is 9 out of 10 people have osteoarthritis, which is the one that affects most of us as we get older. But there are lots of inflammatory types of arthritis that affect lots of young people, including kids. So arthritis is a disease, there's a group of diseases that affects all age spectrums equally. The problem with osteoarthritis, as Don has said, although it is more frequent as we get older, it is not just a direct consequence of getting older. If 1 out of 3 get it, that means 2 out of 3 don't. You'll see the themes come across symmetrically and across these diseases of aging. So it's a multifactorial disease. Part of it is genetically related, part of it is activity-based, part of it is related to injury and trauma. But there is no one specific cause that causes osteoarthritis, which is the most common type of arthritis. Traditionally, the challenge has been we've approached this disease as it's a disease of aging. As you get older, you'll get it, your joints will wear out, and then you'll have to come see a surgeon and we'll have to do something about it. But fundamentally, we are trying at our program to understand what are the causes of arthritis and trying to understand what we can do to try and slow it down or even potentially reverse this issue of arthritis that we are dealing with. And from that perspective, we really started to work a lot in the area of stem cells to try and see what is the role of stem cells in trying to help in dealing with the issues of osteoarthritis. Stem cells, can I keep going?
Oh, absolutely.
So there's a lot of buzz around stem cells, and although they hold a lot of promise, there's a lot of complexity behind the whole area of stem cells. So there are many different types of stem cells. There are stem cells we all have in our own body, which are there to help repair tissues. And these cells decrease in number as we get older, but they are present throughout our life cycle. And there are then embryonic stem cells, which have all the controversies, and then there are pluripotential stem cells, which are cells that we can actually take, for example, cells from our skin, and then reprogram them to a cell which is very early in its development stage, and then reprogram them back to create new tissues. So for us, in our program, we're actually focusing on stem cells that we have in our own bodies, as well as cells that we can program and reprogram. We are not dealing with embryonic stem cells, and we actually have started the first North American stem cell trial for autologous stem cells for knee osteoarthritis, which began earlier this year, and we aim to finish that study by next year. And this is really our first step into this area. As I said, it's the first in North America to really try and understand the role of stem cells for treating osteoarthritis. But these are cells that patients have in their own bodies that we're taking out, growing them up, and then re-injecting back into the knee joint.
On that area of research, the stem cells, is that something that you two as well are engaged in and involved in? Yes.
Yes. So I'm part of a large collaborative team where we want to put healthy photoreceptors. These are the light sensing cells, in particular cones, which are the ones that are lost in AMD, back into the eye. And I'm working on the part of the problem of how do you get these cells in? How do you get them to engraft? And my collaborators are working on the other part of the problem. Where do we source these photoreceptors? So one group is actually trying to take patient cells and drive them in, force them to become photoreceptors by giving them a bunch of different genes. And believe it or not, there's some hints that that's working. Another strategy is to take IPS, so these would be, again, patient-derived, and use what we've learned about eye development, and again, use a combination of genes and things we put into the culture medium and coax those cells to become photoreceptors. So it's a large problem. It's got multiple components. But yes, we're going to probably one day make photoreceptors from human cells. And whether we transplant those into somebody's eye, maybe down the road, this certainly could be an approach.
Dr. Weaver?
Certainly there is ongoing work in stem cell research within brain and spine at the Krembil. And probably the most advanced one concerns the use of stem cells for diseases of the spinal cord and injury of the spinal cord. But there are many diseases of the brain and spine, and so scattered across the multiple labs that we have at the Krembil, there are a number of other programs ongoing looking at the value of stem cells and their treatment of the full range of diseases that are presented here across the three of us.
Is that the main area in which science is either most new or has most promise, or are there other ones that are equivalent? Say, I'll start with you when we go through.
Well, I'm rather biased.
Good man. Join me.
I don't personally do stem cell research. I, as I said, make drug molecules, being a chemist. But I think if you look at the full range of therapeutics that are out there, speaking now not for the whole institute, but just for the neuro portion, brain is tough. It's tough making drugs for brain. It's tough making therapeutics for brain. It's unfortunate that neurology is sometimes referred to as the diagnose and adios specialty, because we see you and we say, bye, several weeks ago, I was standing in the hall with a puzzled look, something I do frequently, and another individual went by and said, "Oh, a confused neurologist. Is it 81 or 325 milligrams of aspirin, the dose?" And so I think that reflects the fact that historically, neuro has been an area where there's not a lot of therapeutics. And so we're looking at all possible options. And the options are drug molecules, the things that historically we are interested in. Things called biologics. So these are bigger molecules. These are proteins. These are antibodies, things of this nature. And of course, stem cells. And so, if you really are committed trying to find cures, which, as you heard from that video, we are, then we look at all possible options. And certainly at the Krembil, we are looking at all of these options.
Dr. Wallace, in your field, what are the newest or the most promising techniques?
So actually, in the eye field, things are very exciting, because only about 25 years ago did we even identify genes that cause some forms of inherited vision loss. And right now, there are clinical trials for gene therapy for patients who have these inherited forms of disease, which is actually, it's incredible, because I think people have always thought that once you've lost your vision, there's no going back. Yeah. It was diagnose and adios as well for patients with these conditions, because there really wasn't anything to offer them. Aside from gene therapy, there's also retinal prosthetics. So if you don't have a functioning retina, we're going to give you a chip that you implant in your eye and basically talks to a camera that talks to your brain. And Dr. Rob Devenier, for example, is leading an Argus 2 trial on a retinal prosthetic right now at the Toronto Western. And that's taken patients who've been blind for years, no light perception, into being able to see shapes. And okay, it's not reading, but okay, they can actually ambulate around their homes. That's remarkable. I think there's going to be a whole new generation of biologics and small molecule drugs that are going to be used to improve or delay how quickly you lose neurons. I think they'll be tested in people with inherited forms of retinal disease because it's simpler in a way and we understand it better. But then I think that will be disseminated more broadly to people with the kind, where they don't have a genetic form. So these are good days. Many things are still back in the research area, but they're doing things that 20 years ago people would have not thought possible.
Just one thing, when you say biologic and small molecule, just explain that for me if you don't mind.
Sure. So biologic is a protein or an antibody. So anti-VEGF, Lucentis treatment that people get for AMD, that's a biologic. A small molecule is a chemical. And I'll defer to Don, but these would be things you might synthesize in a lab or extract from a plant, but they're not proteinaceous in nature.
Dr. Mahomed, in your field, what are the more promising elements or the more recent?
So in addition to stem cells, one of the fundamental things where the paradigm is shifting because, as I said, we are now understanding that osteoarthritis is actually multiple diseases even in itself. And trying to understand that fundamentally is going to be very important as we start to break this apart into multiple different diseases, because that allows us to then understand the mechanism of disease and to provide new targeted therapeutics. So there is a subset of osteoarthritis which is a lot more inflammatory based than it is degenerative. And the treatment options for that cohort of patients is going to be very different than those who develop arthritis from an injury they had 25 years ago. Where this really steps us back into is really into the world of precision medicine. And I think this is going to be one of the fundamental shifts in paradigm, at least how we approach treatment of arthritis care. Up till now, the standard care, and it is today, if you come to my clinic, it's a stepped approach. You're going to come in with arthritis, you're going to be told, do some physiotherapy, take some Tylenol, take some anti-inflammatories. You go through a stepped process, and you take some cortisone, et cetera, until all of those don't work, and then we're going to talk surgery. But if there are a subset of different diseases, people's response to those treatments is going to be variable depending on the disease you have. And as we understand this, our hope is to actually tailor the treatment recommendation based on the subset of the disease and the probability that you're going to respond to that treatment directly, rather than going through a sequence of steps where some work and some don't work, and some of the treatments do carry side effects. So as we start to understand the genetics and the biochemical profiles of our patients, as we study their genetic makeup as well as their biomarkers from the serum and blood level perspective, we're hoping to get to a day where we can actually tailor your treatment recommendations to what will work for you more effectively than going through this shotgun approach.
Is that what you mean when the phrase is used, personalized medicine? Is that another part of this?
It's in that same philosophy where the treatment is tailored much more to the disease you have rather than just a stepped algorithm. I mean, in this area, we're sort of borrowing from the world of cancer, where if you have cancer, you don't get thrown every cytotoxic chemotherapeutic agent. You get treatment based on the type of cancer you have. And that world in cancer genetics has moved along much farther than we are in the world of arthritis. But we're starting to apply those same principles and scientific tools so that we can get to a more precise treatment modality.
There's another area that, then we'll go to more general topics. This idea is it translation research that we talk about? I'll start with you this time, and we'll go to Dr. then over here. What is that concept first, and how does it apply, and what does it promise?
Okay, well, translation research is what everyone wants. No one wants to fund, and it's very, very difficult. It's where you actually take what you've learned in the lab and you actually apply it to patients. So it would be, for example, you've discovered you want your cells. A very nice idea is, can you put cells into a patient's eye?
Okay.
Okay, so maybe it works in the lab. Maybe you can improve the vision in the animals you're testing. But now you want to put those cells into people. And that becomes quite a challenge because people it's more complicated. The foremost thing you would have to think about is safety, and it's very, 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 very expensive to operationalize that. Mm-hmm. So you would start from even just applying for permission from Health Canada to do it. And not to mention, even if you have all your ducks in a row. So in my case, I have a vault of photoreceptors. I have a way to make them. I have a way to make sure they're safe. I know that they aren't going to give anyone a disease. It would still take several years to get the permission to do it. And then, which patients are you going to use? And
years, though, you said.
Years. And what clinicians want to do this? And then do you have a protocol? So a recipe, how are you going to run that trial? So these are all parts of the pipe, we call it a pipeline, from what goes on in a lab like mine to what might happen in an OR with a vitreoretinal surgeon, and you hand this person a syringe of cells and you ask them to inject the cells.
Dr. Weaver, I'll go to you on that translation research and what you see in it and the impediments that it sometimes seems to carry.
So at the Krembil, we have basic science researchers, we have translational science researchers, and we have clinical researchers. And so it's important to recognize that we have all three broad categories of researchers. So even though the expression is somewhat overused, we definitely try to be bench to bedside, and hopefully bedside to bench, recognizing problems in the clinic and taking them back to trying to come up with basic science solutions. So if one looks at the funding issues, basic science, there are government programs through CIHR, NSERC, and whatnot that can sort of fund this. Clinical research, depending if it's being done through a corporation, frequently has financial support through that. Translational research, although it's the crucial one, it's absolutely crucial, because that is the research which takes the basic science insights and actually translates them into a product, into something that's useful, that's going to make a difference in the lives of patients and people, is the one which is the most challenging. And it's challenging not only from the point of view of getting it funded, it is challenging in other aspects. We always have to worry about the commercialization of it, intellectual property issues. It goes on and on. So this is an area that really takes a whole lot of effort for us, but I regard it as probably one of the most important things that we do, is using all the wonderful basic science that is done and converting it to products. Certainly, if we criticize science in Canada, it's in this area of translational research. We have phenomenal basic science in Canada across many areas. Where we are failing is we are failing to take our basic science and to convert it to products.
And again, the question is naive, and I know what it is. Is that because the research is so fresh and innovative, and those that are in position to either approve or forward it are not equipped, to be blunt, to give a ready assessment, and they err on cost, or is it a set of other factors? I really don't know.
I mean, there certainly are a huge number of factors. We call it the valley of death.
That's
fine. You know, you have a wonderful scientific idea, and you're going to convert it to a product, and it dies. It really is challenging. I think the biggest hurdle is funding. It is exceptionally difficult to fund translational research in this country. In past, I have worked a lot with venture capitalists, sometimes called vulture capitalists, but these are individuals who are absolutely essential sometimes in taking a product and moving it ahead. The government agencies are more interested in basic science. They're not really interested in doing this. In my own work, where we try to make drug molecules, so if you had a starter molecule, sometimes we have to synthesize 3,000 analogs of it. So, you know, just tweak it, and constantly trying to make it a little bit better, a little bit better. We call this process methyl ethyl propyl futyl. And you know, so we have to do that. That takes a lot of effort, a lot of time, and this is not something that a government agency is going to fund. That is one area. You know, you have to have an appetite for risk. Yeah. I suppose, you know, historically Canadians are looked at as being a little less risk-taking than, say, Americans. You know, you have to have an appetite for doing this. In the 1990s, I had a compound which we put forward as a drug for Alzheimer's disease. We took it to phase 3 human clinical trials. We set up a company, got it listed on the TSX and NASDAQ, and raised about $150 million. and put that all on the clinical trial, which failed. And there are still people who don't speak to me. And in some cases, that's not so bad. It's a very challenging area. It takes a lot. And I think it's extremely important, and it's an area that really needs better support within our country.
That's excellent. Dr. Mahomed, same subject?
I would echo what's been said. I think it is a very challenging area, but I think it is the area which has the greatest potential to take what we learned in the lab and take it to our patients. The nice thing about working in a place like UHN and at the Western with the Krembil Research Institute is that we have the constellation of the basic science and we have excellent clinical care, and that collaboration really is one of those synergistic facilitators for translational research, because oftentimes the paradigm is you've got the basic scientist sitting in some institution somewhere and the clinical side of the house sitting in another place, and there is no crosstalk. So I think at least from that perspective, we've helped move that agenda forward by bringing the two sides of the house together, and that's really helped move this agenda forward.
How much are you guys allied with other institutes, either here or around the world, in this particular area, the cutting edge, as the cliche has it?
Well, so my program has collaborators all over Canada and some in Europe. The other investigators in my program similarly have collaborations all over the world. Some of them actually are working actively with, for example, pharmaceutical companies to further translate their compounds into potential clinical trials. So this is part and parcel, I think, even in the basic science world, we are more and more straddling the divide between basic and translational. And we are closer and closer ties to our clinical colleagues, who tell us what they see, they see the problems are. And that does change how you might think about something you see in the lab.
Do you find that as well? Is that part of your approach to this? Is there a lot of connection with institutions or private scientists, public or private, outside of here?
So yes, I think it's being more greatly appreciated that progress in these complicated issues really does require a greater degree of collaboration. And so certainly across the neuro aspect of the Krembil, we have collaborations between basic and clinical, collaborations throughout the country, throughout North America and throughout Europe and other locales, and collaboration not only with academic sites but with government labs and with industrial labs. And so we certainly are pushing that. However, I want to put the other side on this, and that is if you are doing commercializable research, then there are times when you can't collaborate because there are intellectual property issues that we have to be constantly aware of. Being a medicinal chemist, in our lab, the joke is in our lab that when you go to sleep at night, you put tape across your mouth so you don't talk in your sleep. So if we are in a conference room and we're talking about our molecules and people have written it on paper, when we leave the room, we actually go to the garbage pails and extract the paper, take it out, shred it. We make sure that the boards have all been cleaned, and in my own lab where we have glass up on the fume hoods, and somebody may have been working on with a marker pen, thinking about the molecule. If you look up and you see somebody in the lab that you don't recognize, every fume hood has got a bottle of acetone in it, and it comes out and they squirt it, and so that the acetone drips down and makes the ink all go away. So, that represents the fact that a public disclosure of a molecule can ruin patentability. So, yes, collaboration is important, and we do collaborate, but you always have to think, what am I going to do in order to preserve the fact that I can get patent protection? Because if you can't get a patent, you ain't going to commercialize it.
Okay, to go to a more general level, in particular, just thinking of the audience that is here to hear you, this is, as I said, fairly plain. People that are of advanced age or are advancing towards advanced age usually have a basket either of concerns, worries, or anticipations. What are the two or three things, I'll start over on this side, 2 or 3 things that people who are in advanced age, who are old, or who are approaching that, should be thinking about, are thinking about? Just go ahead.
Thank you. I want to follow up just one
Yes,
comment
go
on
right ahead.
collaboration. So I think the other area of collaboration that we haven't touched on is really the folks in this room. So collaboration, in addition to science, involves all of us. And it's partly going back to the issue of funding, particularly around difficult, high-risk initial studies. So, I think it is paramount that we have the support of folks like yourselves and our grateful donors who support some of these high-risk ideas. For us, for example, the clinical stem cell trial we're doing is completely funded through philanthropy because we could not get that done through a CIHR type scenario because it would be viewed as too high risk with no pilot data. And that trial, which is costing us $1.2 million because each patient is costing $50,000 to go through that trial, is completely funded by support of people like those who are in this room. So that partnership and collaboration, I think, really needs to be acknowledged and is very important.
You've done so. The three
things. So I think from the world of arthritis, it's still relatively simple motherhood statements, but activity is important. So keeping mobile and having joints that are flexible and strong is very, very important. Weight is very important, to keeping your weight under control, because not only is it a mechanical issue, but our research is now showing that actually having additional weight, particularly some of this abdominal waste, is actually important. Don, take note. For
You're a nasty bunch.
for the inflammatory part of arthritis. So although you're carrying additional weight, that excess weight also leads to excess inflammation in the body, which is also linked to issues of diabetes and hypertension, but it is also a key player for arthritis. So activity, avoiding excessive weight loss, excessive weight gain, and keeping your joints strong and your muscles strong is actually the best thing you can do to try and prevent this problem.
Dr. Wallace?
Okay, all of those for vision health, but also don't smoke as a huge risk factor, well, significant risk factor for some of these age conditions. If you're a diabetic, you absolutely must have your vision checked regularly. You may never develop what we call diabetic retinopathy, but you may do. And actually at the earliest stages, ophthalmologists can actually intervene and rescue your vision. You should have a regular eye exam because, for example, glaucoma is a silent disease. You can actually end up with quite advanced vision loss and not even realize it. And that's very simple. You go and you have your pressure checked. And there are pressure-lowering drugs that can slow down the progression of the disease in many cases. So have your eyes checked and don't smoke. Stay active and keep your weight down.
Sir?
Thanks.
And don't sell drugs outside.
So, in the clinic, I got a lot of questions, not only from the patients, but from their families. And it frequently starts off with, my brain is what makes me me. It's rather important. How do I protect my brain? And the two things that are usually of utmost concern is, how do I try to prevent myself from getting a stroke? And how do I prevent myself from ending up with a dementia? And those are the two most common sorts of questions that I get, especially from individuals who are concerned about what's going to happen to them as they age. From a stroke point of view, stroke is a vascular disorder. A blood vessel becomes blocked in the brain, and a part of the brain doesn't work so well anymore, and that is a stroke. And so all the risk factors that we have been discussing are central to it. Blood pressure, diabetes are two huge, immense risk factors. Smoking is also a risk factor for stroke. And so, certainly those are very, very important issues for stroke. Much more controversial are addressing risk factors for dementia. It's not quite as straightforward, but believe it or not, smoking, obesity, and diabetes are also risk factors for dementia. So they're also in that group. But if we get into Alzheimer's, the big thing is people come in and go, I'm up to 2 hours of Sudoku a day. Is that enough? Yet, you know, you go, no. There's a debate about certainly keeping active, keeping physically active, keeping mentally active is good. But you know, if you participate in the various computer games, the keep your mind sharp, or if you do Sudoku, is that going to make a difference? That's open to debate. The other issue is that by the time people come see me, with the patient, for example, who's in the early phases of dementia, a lot has already been happened. The dementia has been there for 15 to 20 years by the time they actually present with you know, symptoms of sufficient magnitude to see a physician. So you know, really one of the big crucial areas that we have is we've got to diagnose it earlier and earlier so that we actually have a better handle on doing those things. Will they make a difference? So right now, pursue a healthy lifestyle, keep your weight in check, and the various other features such as blood pressure and smoking, I think will work against all the disorders that we're talking about.
Well, before we wind it up, I should like to just give a small emphasis that the afternoon's exhibition and revelations were organized by the Research Institute, certainly directly to give acknowledgement and thanks to the people who have supported the Institute, which basically are the people that are sitting here before this extremely worthy panel. The Institute...
Can I clap for that?
Yes, you may. And if they shadowed the event in any negative way by hauling in someone who needs a consciousness scan, then I'll apologize for that myself. But you have seen the quality of the personalities and the minds of some of the people that are engaged in the Institute. Also, you've seen something of their willing hospitality to participate in an event such as that. So I would like, by my way of conclusion, to say thank you very much to the three panelists, and I hope you join with me. Thank you. I'm off now to the Senate hearings.
Thank you. Well, don't leave. I have something for you. So, as well as thanking our distinguished presenters, Dr. Nizar Mahomed, Dr. Valerie Wallace, and Dr. Dawn Weaver, and our fabulous facilitator, Mr. Rex Murphy, a small token of appreciation for you.
Pose again, eh?
Perhaps the key to aging well. So thank you very much. And I really just wanted to take a moment to thank all of you, our incredible supporters. You really enable the brilliance of the work that happens at the Krembil and with these incredible scientists. So thank you very much. That concludes our presentation for today. Our panelists have agreed to stay for the next 20 minutes, so please approach, ask your questions, and there's a small token of our appreciation on every chair, so don't forget to take those home with you. And again, thank you very much.